Hello, everyone. Welcome. This is the inaugural JAAD International webinar, and I am so happy to have everybody around the world joining us with this. And I'm so grateful to our amazing panelists who have really agreed to give of their time today to join with us. It's really a tremendous honor. JAAD International is a brand new journal that is joining an old and established family with the AAD, with Elsevier, and so we're really excited to help kind of facilitate, this type of thing. As we think about what are the most appropriate things, what are the most pressing needs, what are the most important issues in dermatology right now, certainly, as I think about that, you can't argue that dermatologists around the world are being called on in various ways to address the COVID-19 pandemic. And so thank you, everybody, for joining us. There is an opportunity to ask questions as we go. So everybody who is listening, feel free to do that. I can't promise I will get to every single question because there are a lot of participants, but I will absolutely try, and I will try to at least distill out some of the key themes that we're seeing. But what I'd like to do is just start off with introductions, and then we'll kind of go from there. So I'm Jonathan Kantor. I'm the editor of JAAD International. I am joined by really this all-star cast of dermatologists from around the world. We have Dr. Esther Freeman, who is waving very nicely to us. Who is the director of global health dermatology at MGH at Harvard Medical School, among many other things. She's also the principal investigator for the AAD COVID-19 registry, COVID-19 task force, a whole bunch of other things. If you don't know who she is and you've read any COVID articles, then you probably haven't read the right COVID articles, because she's been on a whole bunch of really great ones. So I highly recommend all her stuff. We also have Dr. Carrie Kovarik, who is the director of global health dermatology at the University of Pennsylvania, which of course is very dear to my heart. I've known Carrie for a long time. Carrie is awesome and brilliant, and also part of the COVID-19 task force, and also on those really key AAD articles, and really an expert in the field, an expert on everything derm path related as well, and derm path related as it relates to COVID-19, and also a real international teledermatology authority as well. So it's great to have you here, Carrie. Thank you so much. We have Dr. Aisha Sethi who is the director of global health dermatology at Yale School of Medicine. So thank you again for joining us. Who again is somebody who, this is near and dear to her heart. She's a real expert in this area, in this field, and it's so helpful to have somebody with such a deep and broad perspective joining us. And we also have Dr. Choon, of course. Let's not forget him, because he is joining us from midnight in Singapore. So thank you again. He is a consultant dermatologist in Singapore. He's also the senior author on an article we published in JAAD International on COVID-19 and skin manifestations that really tried to essentially review the literature that was out there on an interim basis to try to put that in perspective. So thank you again, and thank you for joining us at this crazy time. What I'd like to do, everyone, if it's okay, is I'm going to start with having Dr. Freeman give us a brief slide presentation that is going to kind of address some of the major themes for those of you who have missed some of the recent work on COVID-19 on the skin. She's going to kind of go over that in kind of an organized fashion. That's probably going to be about 10, 15 minutes. So that's not going to be the bulk of this webinar. Most of the time is going to be spent with all of us chatting back and forth, addressing some of the cutting edge therapies and the cutting edge approaches and the cutting edge challenges that we're all facing. And everyone, feel free again to use that question box liberally, and we will kind of go from there. But I will let Dr. Freeman start off with the slide presentation, and we'll go from there. And again, thank you again to the panelists. Thank you again to everybody joining us. This is very, very exciting. And Dr. Freeman, I'll let you take it from here.
Great. And can you guys hear me okay?
Yep.
Absolutely.
Okay,
yes.
Fantastic. Well, I'm really delighted to present to you today. And all of you have just disappeared when I shared my slides, so I'm sure someone will tell me if they suddenly can't see anything. As I mentioned, I'm a director of global health dermatology and the principal investigator of the COVID-19 dermatology registry, which is a collaboration between the AAD and the ILDS. And my job today is to give you a little bit of a whirlwind tour of COVID dermatology. And just to mention my disclosure, particularly that the International League of Dermatologic Societies provides financial support for the COVID dermatology registry. So back in the beginning of the pandemic, which is hard to imagine is over a year ago, we launched a collaboration between the American Academy of Dermatology and the International League of Dermatologic Societies in terms of a registry that's collecting cutaneous manifestations of COVID-19, as well as flares of existing dermatologic conditions in patients who already have COVID-19. And why did we launch a registry? Really, the idea is global reach. So you could be sitting, in your clinic in Madrid and see one type of patient, and individually one case may not mean that much, but then we start collecting cases from Boston and from South Africa and different locations around the world, and those disparate observations together can form different hypotheses, and that's really what happened with COVID-19 dermatology. I think it's important to understand what registries can't do, and they're really not good at, they basically can't do population-based incidence or prevalence. So I can't tell you of everyone with COVID-19 what percentage of people will get a dermatologic manifestation. So really just think of the registry as a giant case series. Where are we now? We're at over 1,100 cases from 42 different countries, and this is actually purely on dermatologic manifestations of COVID-19. We are now at over 400 cases of COVID-19 vaccine manifestations, and I'll talk a little bit about the COVID vaccine at the end. So that's obviously a hot topic. So a little thought-provoking question for you, looking at all of these photos, which of these do you think might be COVID-19? So we've got dorsum of someone's hand, we've got a young child's feet, and we have a man's chest with a pernio rash, and then we have some vesicular eruptions on someone's palm. So these are actually, wrong button. These are, oops, sorry guys. The system is challenging. Yeah, so these are actually all COVID skin manifestations. And the reason that I put these up here is just to show the incredible breadth. I think we've counted more than 30 different skin manifestations in COVID-19. And it's hard to imagine another infection that has so many different manifestations. Particularly the one that surprised me was this baby's feet here. This is a 2-month-old baby, and this is a case I probably would have missed. This was recently published in PedsDerm in 2020, and you can see this actual reticulate purpura on the sole of this 2-month-old baby's feet. So these are all different COVID skin manifestations. So one analysis we've done, and we've done at this point, there's many wonderful analyses out there, not just from us, but from other groups as well, looking at the full spectrum of dermatologic manifestations. This is one of our analyses from 716 patients. And just to give you a sense of who's reporting in the registry, about half of the reports are from dermatologists, which means that the other half are not. I actually view this as a strength of the registry because, especially if you think about the beginning of the COVID epidemic, dermatologists were really not necessarily on the front line, and patients with rashes were really being seen in the emergency department and in the ICU, not necessarily by dermatologists. I think one major limitation to the registry is primarily a white population, 80% white, which I think does not reflect the burden of COVID-19. Just to give you a sense of what's being reported, and I think this has been echoed in other studies as well, pernio, very common, also morbilliform eruptions, urticaria, macular erythema, vesicular eruptions, and retiform purpura. So this is a spectrum, and I think what's so interesting is that different dermatologic manifestations have different severities of disease. So they're not all the same. So over on one end, we have pernio, that's over in our green area. So these are patients with less severe COVID-19. Only 16% were hospitalized. Contrast that over on the far right with retiform purpura. These patients were 100% hospitalized and 82% were in fulminant respiratory failure. In the middle, we have kind of this middle group that we'll focus on for a moment of patients that were kind of mixed in terms of how severe their disease was. So just to give you a few pictures, so morbilliform eruptions, very common, in fact, the most common full body rash that we see in COVID-19. And I think in some ways that's not that surprising. If you'd asked dermatologists ahead of the pandemic, what if there was a new virus, what kind of rash would you expect to see? And I think many of us would have said morbilliform. This is an example of an urticarial rash. And so this was a patient who on day 1 had fever, headache, sore throat, and then developed the urticaria on day 12. And it actually lasted for a good long time until day 25. We also see patients who develop urticaria as their first sign and symptom of COVID-19. So it's not always after COVID. It's sometimes, you see the urticaria first and then the other symptoms come as well. Vesicular rashes, also noted, you can see here on the palm and on the rest of the body as well. And then to talk a little bit about this more severe group. So retiform purpura, this net-like appearance, and the actual pathophysiology here is actually a thrombotic event. Retiform purpura. So retiform purpura is on the more severe spectrum, and this is the pathophysiology here is actually with clots underneath the skin. On the other end, we mentioned we have pernio, which is probably one of the more famous cutaneous manifestations that we've seen in COVID-19. This tends to travel with relatively mild disease. The pictures I'm showing you here are all in lab-proven cases, so PCR positive or antibody positive. And I just wanted to point out that in darker skin tones, this can look a little bit different. This is from JAAD case reports. And you'll see that the erythema and the violaciousness can be a little bit more subtle. This is an important study by Colmenero et al. Showing that there's actual SARS-CoV-2 that can be found in the toes. That little white arrow is pointing to an electron microscopy picture of a coronavirus sitting in someone's toe, even when their nose was PCR negative. So the SARS-CoV-2 can hang around for a little while. So I wanted to just put in this thought question for you to kind of think about, which is that a patient comes in, and this happens all the time in my practice, a patient comes in with new pernio or chilblains. They've never had pernio or chilblains in their whole life, and they deny walking outside in the cold or anything like that. They test PCR negative about a week after pernio starts, and then 4 weeks later, you antibody test them, and they're also negative. What do you tell the patients? Patient, do you say you definitely didn't have COVID? You did have COVID? What do you say? So I think one thing that's important is that thinking about the timing of testing. So PCR is often negative because the toes themselves can only sometimes start 1 to 4 weeks after infection. So if you were infected several weeks ago, we would not expect your PCR test to remain positive. I think the other really tricky piece is that COVID toes patients actually make very low level of antibodies, and they're often IgA positive, which is not routinely tested on commercial tests, rather than being IgM or IgG positive. And I'll show you a couple examples of this. So from our registry, we know only about 15% of our pernio cases test positive by PCR, and really the timing matters. So this is a study we published in JAAD, and for the moment, just focus on the left. You'll see that PCR positive cases, they tend to be PCR positive closer to the onset of dermatologic symptoms. So here, the green bars are PCR positive patients, the red bars are PCR negative patients. And you'll see on average, those that were negative were tested later. Now focusing on the right side of the graph, you'll see antibodies. So the green again here is PCR positives, and here the purple is antibody positives. So peak antibody positivity is around 30 days. However, it gets really complicated for mild COVID-19 because actually there's a robust T-cell immunity as part of it. And also people have rapid decay of antibodies with COVID-19. So unless you're kind of serially testing people, you may not catch them in their brief moment of antibody positivity. And the reality is you're not probably serially testing people for antibodies every single week. I think this is another great study that was recently published by Hubice et al. In JAMA Dermatology that looked at the interferon alpha response, which is much higher in patients with chilblains, comparing those to patients who had severe COVID-19. And what's so interesting about this is similar to a type 1 genetic interferonopathy, which might also explain why patients don't make a big antibody response, because basically they're having a really robust, excellent interferon response. It clears the infection before really inducing significant humoral immunity. And then one of the last two things I wanted to talk about is just about long COVID. So we know that COVID can persist for a long time in other organ systems. And what's interesting is that it can also persist for a very long time in skin. So this is a study that we published in Lancet Infectious Disease. And you can see particularly, for example, with pernio or chilblains, which is the top bar there, you'll note that, and on the left we have all cases, and on the right we have lab confirmed. You'll note that there's a substantial number of patients, not substantial number, but there are some patients who have their pernio or chilblains or other skin symptoms lasting longer than 60 days after infection. So this would be a long hauler. This was really picked up by the press. I think a lot of people have interest in the fact that this is persistent, potentially inflammation lasting a long time. And I just wanted to give you one example of a patient like this because I think it shows a lot about timing of testing and also how long these symptoms can last. So this is a patient who had fatigue and a cough. She developed pernio about a week after her initial symptoms. She ended up going in for healthcare evaluation on day 20. and she was PCR negative at that time, which makes sense. It was 20 days after her initial symptoms. So she was, at day 20, she was negative on commercial antibody testing. Now, what's interesting is she had continued worsening pernio, and they actually had access to a research lab that was doing IgA testing. So on day 24, she was actually IgA positive, but continued to be IgG negative. So keep in mind that if she were tested on commercial antibody testing, she would be negative. But she did indeed have COVID, and she was IgA positive. She did eventually become IgM positive around day 41. But if you're not testing patients, regularly, you're really going to miss this. So I just want to make it clear that someone who has negative antibody testing doesn't mean they didn't have COVID, because this patient you basically would have missed if you tested her on day 20 or day 24 if you weren't doing IgA. Now, she actually still has persistent pernio now over 130 days later, and this is what her feet currently look like. So I think the other thing that's interesting is we're starting to see recurrent pernio flares. That the initial pernio flare happened with COVID back in March or May. People did very well over the summer, and now they're having recurrent pernio flares in the winter. And these patients are testing PCR negative, so we don't think they got pernio again. We think that something about the cold has triggered them. And this also raises questions for us about pernio pre-pandemic. Is it possible some of these pre-pandemic pernio cases were actually mediated by viruses? And a couple of my patients with some recurrent pernio flares. And then the last thing I just wanted to mention was about the vaccine. So we're seeing a big rollout, of course, of Moderna and Pfizer vaccines. And now in the registry, we are collecting vaccine skin reactions. And this is from one of my colleagues, Dr. Kim Blumenthal, who's a really world-class allergist at Massachusetts General Hospital, who's running a lot of the vaccine allergy issues at Mass General. And so one reaction that we're seeing a huge spectrum of different reactions, but one that we're seeing, particularly with Moderna, is this delayed large local reaction. This happens about 7 to 8 days after Moderna. And I just want to differentiate this from patients who get a local injection site reaction, usually day 1 or 2 after Moderna. So this happens 7 or 8 days later. And we get a lot of questions about, is it safe for the patient to get the second dose? And the short answer is yes. People have actually been doing very well with the second dose after getting this kind of reaction, but I think it's a little surprising and upsetting to people because all of a sudden, a week after their vaccine, they get a big red plaque on their arms. So our ongoing work, please contribute. We'd certainly love to hear both about your COVID dermatology manifestations and also about vaccine skin reactions. This is a link to the registry, and you don't have to be an AAD member. This is open to anyone. And a huge thank you to the team across many different countries, and just a lot of effort from a lot of people to bring all of this data together. This is really a huge collaborative effort, and I'm so appreciative of everyone's involvement. And with that, I will end my presentation. Thank you.
Thank you so much, Dr. Freeman. That was fantastic, and just a really brilliant, concise overview, kind of the state of the art. So I think it was super helpful for everybody listening. A couple questions I just wanted to throw out there that have been asked in the chat box. One, somebody asked, they said, why does pernio typically appear in a delayed fashion, mechanistically? Any thoughts from you or anybody else on the panel on that?
I think the way I think about it now, especially we have the data on interferon alpha, and then it's really this interferon alpha response. I almost view the toes as like an innocent bystander. That basically you're having, these patients are controlling the virus very well with their interferon response, and it's different than patients with severe COVID who actually have very low interferon levels, like too low. So you're actually doing, I always tell my patients, you're doing too good a job. Your body did a great job with this great interferon response, and your toes were kind of an innocent bystander. And so I think of it more that the reason it's delayed is that it's really a reaction to the interferon response. I think it's interesting that we do see the coronavirus, the SARS-CoV-2, sitting in the toes, because I'm still not convinced that it's really a direct viral effect. I think it really is probably more mediated by the interferon.
We're going to talk more about where we see virus and histopathologically, why we see it there and how meaningful that is. So that's a really important point. Dr. O, I know, in your study, you've talked about, geographic differences in terms of presentation. What do you see? First of all, what's your experience, in seeing patients in Singapore with this and with your colleagues? And have you seen a similar pattern to what we've been talking about, or have you been seeing something a little bit different?
Yeah, so I agree with Dr. Freeman about the paper she presented earlier. There is not much data on Asian skin data, skin type 4, 5, and 6. So in Singapore, it's primarily type 4, 5, and 6. And the incidence of COVID rash is still not widely reported here. So far, our colleagues have reported 2 to 3 papers on morbilliform rash, the maculopapular rash. So far over here, we have no cases of perniosis or vaso-occlusive diseases. While some people postulate that being here is very tropical and hot, typical perniosis, typical in temperate countries, which we might not see here. But it remains to be seen whether the COVID perniosis is truly due to the temperature or is due to a viral mechanism. This remains to be seen. Yeah, hopefully we have more people around Asia that can publish their work, because at present I think there's still a paucity of publishing reports from this part of the world. Yeah,
that's great, and I think you raise an important point, which is the temperature dependence here.
That's right.
And Dr. Freeman, you were mentioning that you're seeing that that secondary spike there as well. So it definitely is very interesting in terms of it touches on a question that somebody's asking in the chat box, which they're saying, what is the association between interferon alpha response and cold? How does that all connect?
I'm hoping someone can answer that for me, because this is absolutely plaguing me as one of the central questions, which is that clearly there's something going on with temperature. There's clearly something going on with interferon alpha, but how are these two interacting? Is it when we're seeing patients who have recurrent pernio, is this just the cold, like there's somehow COVID has primed them so that they are now going to be more cold sensitive? Like I do have one patient, for example, one of my patients who had PCR positive COVID in the spring, and now she actually can't walk down the freezer aisle at the grocery store. She goes into like full livido, like pernio flares, literally from walking down the freezer aisle in her grocery store. So there's clearly some strange temperature thing going on, but are they somehow re-triggering interferon alpha, or is this different? I don't have the answer to that. I'm hoping someone maybe on this call is going to be inspired to look more into it.
Yeah, no, that's really a great, such an interesting interplay too, because this is, it's interesting how this is kind of a classic example of the importance of empirical medicine, right, and observational medicine. It's the, because we're looking at things that we've seen for years. I mean, we're all dermatologists. Well, yeah, pernio, this, that, sure, we know what that is. But, it kind of makes you step back and say, well, wait, do we really? And, have we kind of been complacent, all this time? Somebody else actually on a related issue asked, they said, because we were talking about, vasospasm, we're talking what's going on. So they're saying, is the bluish discoloration vasospasm in the pernio lesion? And does long pernio have a neurovascular component as well? Is there hyperemia and vasoconstriction as well, typically? And Carrie, it looks like you want to speak to that.
So I'll just make a comment of what we see under the microscope, because well, first clinically, and Esther may have a different experience, but I think overall we see this in the toes as opposed to sort of regular pernio, where you see it much more frequently in other acral sites like the nose and the ears, whereas this is much more focused in the toes, although there have been reports of it in other acral sites. But I think there's something about the toes, right? Because it's much more focused in the toes as opposed to the other pernio. But under the microscope, we also see much more vascular sort of busyness and injury, and even little clot formations in the COVID version than we do in the non-COVID version. We can see little clots in the non-COVID version, but if you sort of sit the biopsies side by side and go through a bunch of them, you could probably pick out the COVID ones more frequently because of that vascular injury. And there's less vasovascular alteration and that typical epidermal change. So, they are a little bit different under the microscope. So, I can't give you the answer as to what the interferon is doing, but there's definite differences.
So just adding to what Dr. O, I hope I'm saying your name right. I'm part of this WhatsApp group from various hospitals and infectious disease physicians from Pakistan. And no pernio cases whatsoever, like a rare one. And in Pakistan, mostly you'll see type 4 to type 6. Skin is rare. Type 6, I would say, is rare. It was mostly erythematous, what they call erythematous or maculopapular or morbilliform eruptions. The way I think of it is there's definitely like like you said, the importance of empirical medicine. Leprosy likes cold areas, right? And we didn't know that till a long time. And then it's the ears, the tip of the nose, the toes. There's something about COVID that I think about it as being almost like a vasculopathic virus. It's something to do, it loves the vasculature, it loves sort of coagulation cascade. And we're also seeing, who knows, we'll see that it prefers a certain temperature. It hangs out, like Esther was saying, it hangs out in the toes. And I really like that description, because if you think about the nose and the ears, me personally, my toes get colder most of the time when I lived in New England and now in Chicago. So there's something about this virus, and somebody will discover it, that will combine sort of all those vasculopathic, the temperature sensitivity, and sort of that hanging out in the toes location in cold areas.
And I would add, I think, to build on both of your points, that we do see in the registry about 10% of the pernio cases are in fingers. So it tends to be in the toes, but 10% in fingers. And we actually have had a number of cases that are nose and ears. So we do see it in those locations, but exactly as Carrie was saying, less frequently than in the toes. And so about 10% had both of the like hands and toes. So kind of COVID fingers is also a thing. I think the other point that I want to make, and this is subtle, and we haven't actually published this, but in chats with Lindy Fox, who's definitely an all-star morphologist who's been working with us very closely from the beginning, she thinks, and I tend to agree, that we've probably lumped too many things under COVID toes. Not that we called it COVID toes, but the media has called it COVID toes. I think there's actually several different mechanisms happening under this, because now with the vaccine, we're actually seeing some cases of erythromelalgia in the feet after the vaccine. And so I think that, and I look back at some of our original pictures of COVID toes, and I think there's actually a couple different pathophysiologies there. I think there's true pernio. I think there's probably some erythromelalgia and vasospasm that I think might be separate from the pernio. And I think that we've kind of lumped it together, like, oh, if your toes turn purple, it's all the same, thing in COVID. And I think there may actually be some subtle differences. And I do think it's important to note that with the pernio, I know Carrie and I have chatted about this, that we might see some clots, but I don't think the clot is the primary pathophysiology of the pernio in the COVID patients, different than something like retiform purpura. And that was a question we got a lot early on, was people like, oh my gosh, should I be checking D-dimers on all my patients, PEs? And the answer is no. So I feel reassured on that front.
No, that's great. And that actually addressed two other questions that were being posed here, which is one person said, in patients who have a history of COVID perniosis, or COVID toes or whatever we want to call it, does it tend to trigger a COVID-like recurrence, a pernio-like recurrence? So is that something that they're seeing again in response to vaccination? And I assume that they're thinking about, is this an immunologically mediated response versus is this primarily viral? And I think that kind of helps to kind of at least tangentially get at that question for hypothesis generation.
It does. And we are seeing, so in the vaccine registry, which, more on that soon, in the vaccine registry, we are seeing cases of pernio flaring after COVID vaccination, which does suggest to me that there is certainly part of this immunologic reaction.
Great. And someone was asking, a couple of people asked on kind of practical clinical questions. So, practical clinical questions in the sense of, number one, do you typically measure, cryos? Are you going to do that in terms of workup? And I think you kind of touched on that a little bit there. But then the other question they asked is, do you pursue further workup before calling the rash COVID toes, before saying, oh, this is pernio? Is there in this day and age, especially in areas where we are seeing really, really high numbers of patients who are infected or coming in, where you're pretty confident if somebody has symptoms of COVID-19, they've got COVID-19. Do you feel like an additional workup is warranted, or do you feel like it's a clinical diagnosis and you say you'll be fine, go home? What do you think? Globally to the group, what do you think about the smartest way to handle those patients?
I'll tell you, this is definitely not a guideline. I have to be clear, because I'm also the chair of the guidelines committee. This is not a clinical guideline. This is Esther Freeman's personal opinion of how I've been treating these patients. Is that, first of all, if someone comes in with like new onset urticaria or a new morbilliform rash, like, oh yeah, and they don't have like some reason like, oh, I just had shellfish last night and I know I'm allergic to shellfish. I am COVID testing those people. So that's one piece that's important. I think with pernio, it's a little trickier. What I basically tell patients, if they're coming in and their pernio onset is very recent, I will say, you know what, probably worth testing you just to make sure that we're not dealing with potentially a still infectious situation, PCR testing them. But I tell them it's probably going to be negative. You probably have, you know, if we don't think it was just you walking in the snow, you might have had COVID like as long as a month ago. So, you know, and I generally am pretty reassuring. I don't do any lab workup on patients except for possibly that PCR test if it's new. I offer them, once they're a month out from their pernio onset, I'll offer them an antibody test, but I'll say, listen, like this isn't going to change the way you do anything, and it's probably going to be negative. Because unless we're testing IgA, which is only available in labs, and unless I'm testing you every single week, I'm probably not going to catch the hot minute that you're antibody positive. So I tell them like, yeah, we can do it, but you're probably going to be negative. So up to you if it's really worth it. And then I only go into any further workup if this patient is someone who has really persistent COVID toes beyond the 60 days. And usually even then, you know, someone really has to have persistence, like 3 or 4 months in. And then I start wondering, okay, am I missing something else? Then I'll do a little bit more of a workup. Or if someone's really having a ton of recurrences, I just want to make sure I'm not missing some other autoimmune trigger or autoimmune disease. And we also know that COVID triggers autoantibody conversion. So it's kind of tricky done. So I'll go into further lab testing until they're kind of like an atypical or weird case, basically.
Any other thoughts from the other panelists on that?
So I agree with Esther, and this will be like my guidelines, like the disclaimer, I'm going to put it out there. So I'll just give an example. I think it depends on the age, like, you know, all of us assess underlying conditions, the presentation, the persistence. Like I saw a couple of teenagers in the last few weeks, one via Telederm from Hawaii, who had been COVID tested before. Yeah, I know. Like, so I had gone to Hawaii for Christmas break, and all the family was COVID tested. So it was COVID toes, not painful, nothing. And I, over Telederm, had this sort of awkward conversation that, you know, it still could be, but how is it possible? I was tested, and well, I like Esther was saying, I think that IgA piece is really key, and I don't know if in teenagers it's the same thing as young children. So I didn't do any further workup in that specific case, but in other cases, like you're right, you know, if somebody has a history of Hep C or, you know, there's other stuff going on, then probably, you know, would individualize the workup.
Great. I think, we've been talking, I'll touch on vaccines briefly, and we'll go back and we'll talk more about vaccines after, because I know everybody also likes to talk about this. Because somebody was asking a question, they said, you know, have you seen any cases with the Sinopharm vaccine? Those of us working in the US, of course, are very biased in terms of what we're saying. This is, by the way, the danger of that registry tribe reporting, right? Because you would say, aha, look, you see, only the Moderna and the Pfizer vaccines, based on the reported literature in the US, lead to any problems. So it's really based on what we have available anywhere at any time. But maybe Aisha or Choon, you can comment on if you've seen any issues with the Sinopharm vaccine or heard of any issues with that in terms of similar reactions.
Yeah, unfortunately, over here in Singapore, it's still Pfizer and coming with Moderna. And today we have no supply of Sinopharm vaccine at this moment. So can't give you much data as of present. Perhaps in the near future when it arrives over here. Yeah.
So I also don't have, especially in Pakistan, it's a Sinopharm or Sputnik, actually, also the Russian vaccine. And I don't know of it. I think it's just starting over. The rollout is just starting there. So
I would definitely encourage anyone who's listening who are in other countries. We would love to hear more than just the Pfizer or Moderna. So if you are in places and you're seeing AstraZeneca, you're seeing Sinopharm, you're seeing Sputnik, any of these, we would certainly love to hear about it, because we are right now, the registry with the vaccine entrance is primarily in the US, and we really would love to hear more about the international experience.
Great. You know, I think, and the vaccine thing is, of course, it's such an important part of the puzzle now, and it's such an important part on so many issues. And that I'm gonna touch on this tangentially because it's something that kind of ticks in my head, and then we're gonna go back to some other issues. But the this is the Jonathan personal opinion now. But you know, the question, you know, the challenge here, right, is that we're dealing with a situation where you know, one of the biggest, I mean, before the pandemic hit in 2019, the WHO declared that vaccine hesitancy is one of the top 10 threats to global health. And that was in 2019 or 2018. So that was before this even happened. Now, of course, we're seeing even more so how that can play a role. What are your thoughts from the panelists in terms of, you know, how we both report this data in the scientific literature, and then what our roles and responsibilities are, whether it's on social media, whether it's on, you know, talking to reporters and things like that, in terms of clarifying, because it's so easy, you know, to see those stories that they latch on to, like, aha. I mean, I remember when we were first, you know, when the vaccines were first being released in the US, you know, anytime anybody had, you know, a sore arm, it was like being reported as, you know, front page news. And the problem, of course, is, you know, obviously we don't want to feed any hype and any hysteria. If there's a real problem, absolutely, it's our duty as physicians to report that. But we also have to be cognizant of how what we talk about ends up getting kind of, you know, you've created a small little snowball and you've dropped it down a hill, and you didn't realize that you're actually on Mount Everest, and that there's a base camp below you. So what are thoughts in terms of how to temper you know, some of what we're trying to do as physicians, as members of the global community, you know, with those considerations?
Yeah, oh, go ahead. Okay, I'll go first. This is an area of huge interest to me within global health, and it's something I, you know, have dealt with, having lived in a few different countries, having a very superstitious part of my family and everything. So personal experience with it, being the only physician. So I think there's a few different things here. And I think vaccine hesitancy and anti-vaxxers, you have to delve into what's the reason behind it. And there's some cultural component to it. And then sometimes if you go to Oregon, for example, Portland, Oregon, you'll find huge groups of moms not vaccinating their kids. I have some family that lives there. On the same, it's amazing. You go to northern Pakistan, you'll find the same group of moms not vaccinating their kids there because when Osama bin Laden was caught, it was a physician who had visited him, who had given some information back, you know, to intelligence. So they thought vaccines were injecting them with some sort of thing that would be used for intelligence purposes. So, and that disrupted the polio vaccination campaign in Pakistan. So I think there's a few different things. One, reach out culturally to different groups based on their religion, their race, their ethnicity, by cultural mediators who are almost like vaccine diplomacy is what I call it. The second thing I think that's important within this arena is doctors were posting pictures of themselves, me included, of first dose and second dose, like, hey, look, I'm doing okay. Or, you know what, I'm not doing great. I've got like some muscle aches and stuff. So I think there's that reach out. There's doctors talking, almost like having a conversation, not talking down to people who don't believe in it. And I think really important, at least in our country, is like reaching out to minorities. And I think there's a history in this country also of doing experiments, especially the syphilis experiments on African Americans. So I don't find it hugely surprising that there's you know, sort of suspicion of vaccination. So I think there's a few different roles we as physicians have, but I don't know if that's taught to us in med school, how to do that effectively. So sorry, that was my little, you know, thing on vaccine.
No, that was brilliant.
Yeah.
Thank you. That was
Okay.
I appreciate your candor, and that was very, very helpful. Anyone else want to chime in?
Yeah, just one thought. I agree with everything that Aisha said. I think I actually gave a talk yesterday to a bunch of teachers who were vaccine hesitant, and I was trying to think about how to phrase it. And I will say, actually, on the CDC website, they now have a whole bunch of resources, like pre-prepared slide decks and other things. Some of them are a little dry, so actually to take to social media.
CDC was dry?
please. I was like, I feel like this is a little peppier. But there are, if you're looking for some technical backup, to provide like numbers and how it goes through the process, that is all available on the CDC website. So that can be helpful background. But I did find that a little bit, like a little bit dry. Dan Sugai, who trained with us at Harvard, who's very active on social media as a dermatologist, has been doing some great posts about this. So one of them is an example of what went through his mind when he was getting the vaccine. And it was like all these, made a social media posts of all these pictures of him going to weddings and graduations and restaurants and all these things. And I think that's a really great way to capture people's attention. I will say, Jonathan, just to get to your point about this data, because sometimes I do feel like, here I am looking at vaccine side effects. Am I creating part of the problem? But I actually view it the other way, which is that if people know what's going to happen, and I can actually dispel that myth that this is going to lead to something horrible, I think that's actually very helpful. And so we've had a lot of people contact us about, this happened to me on my first shot, whether it's an arm or whether it's delayed urticaria or whether it's a morbilliform eruption or whether it's PR. So this happened to me at my first shot. What does this mean for my second shot? And actually the data is really reassuring. People haven't gone on to get anaphylaxis. It's not been particularly dramatic the second time. So I think it's key to think about our messaging. And it isn't just like, oh my gosh, there are vaccine skin reactions, which of course surprises no one, right? But it's more like, hey, there are vaccine skin reactions. We knew this was going to happen. And guess what? You do fine with your second dose. So go for it.
No, I think that's great. And I think that's what, the framing, everything when you're dealing with, the public, and this is something that's super dear to my heart. So if anybody watching, or listening has any interest in this area, feel free to reach out to me personally, because I think, to me, the vaccine hesitancy as a specific issue and behavioral considerations in general, I think are so important, because I think if we didn't realize it beforehand, and we should have, COVID has done nothing but highlight how important it is to say, congratulations, you have a vaccine, and now nobody's going to take it. So good job, right? So I think that's a huge issue. Go ahead, Carrie.
I think it's really important to, if you talk to these groups, to approach them with a little humility as well. Ask them, what it is that's making them think twice about it. And I think sometimes, thinking about it myself, if I was in their position and a doctor was coming to talk to me and just sort of paternalistically say, you need to get this vaccine, I would probably just put my space in front of me. But I think if I was the doctor talking to those groups, if I sort of said, I was a little bit scared too, when I actually got the shot, I was like, well, what if I have a horrible reaction? Is this really the right thing that I should be doing? And said, yeah, I actually thought about all the reasons why I should do it too. I didn't just blindly jump into it with both feet, because I think sometimes the groups think that's what we're doing. We're just like, going and not thinking about it, intelligently. I think they're like, oh, really? You actually thought about this too? And I think it brings us down to the ground a little bit.
And I think being in derm clinic is a great opportunity. I actually ask, it takes more time. So granted, there's that, but, I do ask my patients, especially right now in Massachusetts, over 65s are eligible, which is a lot of my patients. So I do ask them and just kind of engage them in a little bit of a conversation, and maybe you can move the needle, even if maybe you're not moving it to, yes, I'm going to book it right now.
Right.
Like you're like one more signpost of change.
Yeah. Those personal, I think we're hearing everybody saying that, those personal connections, I think with that humility are so important. That's why I'm always like I had my parents have been, again, over 65, my dad's immune suppressed. I'm like, come on, there's no, again, everything is risk, everything is benefit, and you've got to always weigh that. And so that consideration, I think, is really great. How about, over Chiat, over in Singapore, are you seeing, what are things like there in terms of the, general approach to vaccine hesitancy? What have you been seeing?
Yeah, so the vaccination for in Singapore has been rolled out for almost a month here. So we started with healthcare workers. So initial response was a bit low. Even the healthcare workers, some of them were a bit hesitant. Would I get reactions and things like that? I think what Dr. Freeman highlighted is true and good. You can post your first shot on Instagram, on Twitter, and say, nothing happened to me. Or just a mouth sore, but it goes away. I go for my night runs and my dinner after that. That all's good. And so the healthcare workers was the first wave, and now we are launching to the general public, and we will start with the elderly first. So citizens above 65 and 70 and above will get the first wave because they are deemed more vulnerable, and then subsequently the general population. But I also felt that what Dr. Freeman highlighted about the vaccine registry is also very important. I guess the data will speaks for itself. If we can collect data around the world showing that, the reactions are so mild, a mild urticaria, a mild sore, and we show that worldwide reactions are so temporary, no one gets a severe reaction. And then with such numbers and evidence, this can push those who are hesitant to actually think twice again with the real evidence. Yeah.
Great. And I'm going to circle back because we do have some outstanding questions, and they're both outstanding and outstanding, so I want to make sure I address them. One is, Esther, you talked about this briefly in your slide deck, the relationship between, but I think this is worth reiterating, the relationship between COVID stage or COVID severity and the type of skin lesion, because this is going to be a lot of things as dermatologists. When one of the reasons that they're, the internists think it's worthwhile to bother us, depending on where you are, if particularly in community hospitals where dermatology maybe isn't so accessible, is because they're thinking, okay, can you give me some prognostic information here? Can you give me something useful? So, I think it's probably worth reiterating, your thoughts on type of eruption linked with severity of COVID-19 and prognosis.
Yeah, I mean, I'm always a little hesitant to tell someone that, oh, you've got this kind of reaction, so you're definitely going to be fine. But I more view it the other way around, which is that you have, your body is reacting to SARS-CoV-2 in a certain way, right? We know some people control it very well, probably have pretty good interferon responses, control it relatively rapidly. We know some people don't produce a lot of interferon and have another kind of, cytokine situation and aren't controlling it well. I almost view the skin as a little bit almost like a side effect to your body's reaction to the virus. So if you are controlling the virus well and you have a certain profile, that's going to lead to a certain set of skin reactions. So for example, like pernio. Or if you're not controlling the virus well and it's replicating and potentially going to put you in a prothrombotic state, that's going to give you another set of skin reactions. So I almost view it, rather than attempting obviously to view as a prognostic sign, but I almost view it like a little flag. Like, hey, this is what the immune system is doing. And your skin, like we know in dermatology, your skin is a great window into the soul. And so it's almost just a way for us to say, hey, this is like a little bit of a marker of how your immune system might be reacting. But especially because some of these rashes are happening like 1, 2, 3, 4 weeks after COVID, they're not, I think, as useful for prognosis. When you have someone coming in with new onset urticaria, it's helpful because you can diagnose them with COVID based on their urticaria. But with urticaria, I can't really tell you, hey, this means you're going to end up in the ICU or not. So a little bit fuzzy on that.
Great. Thank you. And then I wanted to touch on some things, and I'm going to go back to some more of your questions, everybody, so don't worry. But I wanted to touch on some stuff that I know is also very close to Carrie's heart, which is about the skin and smell and dogs and non-dogs, and talk about some of the ways in which dermatologists, really have. I mean, one of the great things, not the great things, but one of the silver linings on this pandemic is seeing how dermatology has really, kind of banded together to, first of all, function first as physicians, right? Because we're doctors first. And second of all, how, we've tried to do what we can to help out the global community. There's been a lot of interest, of course, lately in, more efficient means of detection, because as much as patients love nasal swabs, that's not, one of their favorite things to do in the world. Carrie, I was wondering if you can speak to the issue about virus in the skin, smell, and if we should start sniffing our patients. And if you do it with an N95 mask, I don't know how effective it's going to be.
Right,
but,
we don't really want to do that, I don't think. But so basically, humans emit carbon-based compounds from their skin, from their breath. Some of them we can smell, and some of them we can't smell. Most of them dogs can smell. So there's been research, some of you have probably heard in the news, like dogs can sense or can sniff out melanoma. They can, here in the same lab that I'm working with, we had dogs smell out ovarian cancer. But they can sense these volatile organic compounds that are being emitted from either the breath or the skin. And we're doing some research in detecting COVID that's being emitted from the skin. Our dogs here at the vet school have actually been able to detect it. It was 98%, but there was so we get this by having patients with COVID and not with COVID sleep in t-shirts overnight, sweat in the t-shirts, send them back in plastic bags. And then we cut the pieces of the t-shirts, put them in this very cool, you can see it online from our dog training from the Penn vet website, but in this metal thing that goes around in the circle, this scent training, and the dogs walk around and smell and have to pick out the COVID smell. And the dog sits by the COVID smell. And the dog sat by this one, and they're like, no, that's not the COVID one. Insisted it was COVID. And they went back and retested the patient. It was actually positive. So we're at 100% on the dog sniffing COVID. And so we got an NIH grant to use a nanosensor, DNA-based nanosensor, to detect basically what the dogs are detecting, these volatile chemicals that are being emitted from the skin, so that we can develop a device that we can detect the odor coming from patients. In the lab, we're doing well with that detection right now, but it's translating it into real world. That'll be the challenge. But we do know that COVID, at least the spike protein, and there have been some tests showing that, as Esther showed, that the actual virus, and you can PCR the virus out of the skin, is, in eccrine ducts, in vessels, and we know that the COVID does enter into blood vessels in the skin. And, so we don't know exactly what the compound is that they're smelling, but eventually we'll figure it out, and it's probably related to a piece of the virus or the virus itself. It's pretty exciting that skin plays a role.
It's so interesting. It really makes me wonder, because I've seen biopsies where they've PCR'd out positive in eccrine glands, as you mentioned, in a bunch of different COVID-related rashes. We've seen it in morbilliform, we've seen it in pernio, but it makes me wonder, if you biopsied someone who had no COVID skin rash,
right,
would you still see, COVID in their eccrine glands?
Right.
Yeah, we haven't done that study. I think once we characterize the compound, trying to see what it is and if it's actually something we might see or be able to do immunohistochemical markers for, we might be able to figure out if that's possible. But yeah.
Oh, that's so interesting.
Great. Yeah, no, I think it's great. And I think it's, I think it's really one of the, really a tremendous example of how we can, really kind of all work together to do some really exciting and interesting things. And it's a great cross-disciplinary, project too. So I think it's awesome. And we only have a few minutes left, and I'm so sorry because there's so many really good questions coming through. I just want to make sure I hit on a few of these. And anybody whose question I've not addressed, do not feel personally left out. By the way, I also have no idea who you are, just so you know. The way I see this, it may be my mom. Mom, I'm sorry I've ignored your question. But no, I don't think she's on. That would be big. I should be. I don't have my phone with me. I'd be getting texts. Are you only ignoring me? But no, we don't actually know who it is who's asking anything. But a couple of kind of related questions. Somebody asked, vaccinate COVID-19 long haulers. Vaccination? Yes, no. Thoughts on how to handle that clinically?
Yeah, that is tough. I think it would probably depend a little bit on, because there's such a different breadth of what we see in COVID long haulers. I think if I were someone who had neurologic or cardiac COVID long hauler, I might be a little bit more hesitant. Someone who, for example, has been dealing with just pernio long hauler, it might depend a little on their symptoms, but that I might be more, if it was something, more tolerable, I would probably be more willing to vaccinate them. Certainly, we know that people with prior COVID, we are recommending vaccination. And certainly anecdotally, I haven't seen this really borne out in the data yet, but anecdotally, we're hearing that people who have had COVID, who then get first dose of Pfizer or Moderna, are sometimes reacting almost more like other people react to their second dose, which makes sense. Your body's seen COVID, you're kind of having this, reaction. When other people are having their second dose reaction, you're kind of having it first. As I said, I haven't seen really hard data on that. That's just more, I would say, more anecdotally. So this is not me unveiling some secret source of data that I have. Just more anecdotally, but so I think it would really, I'm not going to be able to give you a blanket all answer. So I'd say, you know, if people have prior COVID, we do recommend it. With COVID long haulers, that becomes more complicated. If it's truly maybe just the toes involved, I might be more convinced to go for it. But if they have other situations like neurologic or cardiac, that would really make me think long and hard.
Great. Anyone else with any comment on that, or?
I think I agree with Esther. I still have that image of the dogs in my mind. I was just thinking of the TSA using dogs.
Well, that's kind of the plan.
Right? I was just thinking of that. I just couldn't. I was still thinking about Carrie's dog.
Yeah, Miami Heat is using COVID dogs right now, by the way.
Yeah.
So they're doing it at basketball games. So,
I know. They are?
Yeah.
Oh, wow.
South Florida.
My husband. Oh my God, that's amazing. I'm not sure I would like dogs sniffing me out at the airport, but
well, that's why we're planning on developing this.
I know.
Basically,
fascinating.
Yeah,
especially with the eccrine gland distribution and the way the sniffing goes on, and it's in a bubble, it just gets very uncomfortable, the whole thing. So, definitely a nanobiosensor is preferable to the dog, but we'll take
we do have a leg up because a lot of other people want to use breath or urine, and the skin is really not as infectious, right? And so we kind of are better off with the skin than breathing on someone or urinating. And so
absolutely, yeah. You can't. It's invasive, but I mean, it beats the alternative. So
eccrine gland density on your forehead, you know, armpits good, but forehead also. So.
Yeah, but dogs are short, so that's.
I'm not talking about the dogs.
That was the problem they had in Miami. They're like, let the dog sniff you, and I'm like, this does not seem like a good idea.
The dogs, close. Their noses are ridiculous.
Wow. That's amazing.
This has descended into craziness.
I know. I'm sorry. I was just thinking about
I hope people appreciate that this is hopefully the most entertaining webinar on this subject that's ever been done. We have 3 minutes. I want to try to get one other question, which is, and it's very hard to answer on standing on one leg, that a number of people touched on this theme, jokes aside, which is, particularly with COVID toes, particularly with the controversy, how do we really, they're sort of touching on the epistemology here, right? How do we really know that this is, related to COVID? What is our confidence level? And any thoughts that, in terms of sound bites that we can at least say in response to that?
Yeah, so I think there's really very strong evidence that it is related. I think the question is brought up is all pernio during COVID-19 pandemic. Oh, did I?
And we lost her. But anybody else want to?
We didn't want to know what she had to say anyway. There.
It was going to be the secret of of life.
No.
Esther, you had the secret of life. You're leaving us hanging.
It was like the secret of the universe. It's not.
I know. We lost it. It's all over.
It was like the key moment that it was just like, and you're just. Sorry, what I was trying to say was that there's a lot of great data that they are related, and we have so many patients who had PCR confirmed disease, and like 7 days later or 14 days later, we can completely date it. They get pernio for the first time in their entire lives. It's very hard to say, okay, you had what we know is lab proven COVID, and then you get pernio for the first time in your life. That's totally unrelated. Very, very hard to say that. So, and I think really looking at the increasing amount of data showing that direct link. And for example, the data from France where they were able to IgA test people, for example, 30% in this particular cohort in France, basically IgA positive, 30% of their pernio cohort. We're not testing IgA in the United States. So, by looking at these, the point I really want to make is by looking at these commercial antibody tests, if they're negative, that means almost nothing.
Yeah, and that's actually that's a great point, I think, to end on, which is that, we've got to remember the limitations of our testing, whether it is dogs or whether it is IgA testing, all right? We've got to remember the limitations of what we're doing. But I want to make sure we wrap up on time for everybody. So I'm going to cut it here. And I want to just say thank you so much again. I mean, this has been, as everybody watching can tell, we have been having a blast. We can't see you, so hopefully you've been having as much fun as we have. But I want to give a huge thank you again to all of the panelists, to the entire team at Elsevier, especially Bobby Brinson, to the entire team at JAAD International. Charlene has been such a huge help with really getting this out there, and Dietra as well, and everybody, and Mary. Thank you so much for doing all this. We really appreciate it. And again, thank you again to my panelists, Dr. Esther Freeman, Dr. Carrie Kovarik, Dr. Aisha Sethi, Dr. Choon. Thank you guys. Thank you for joining us. This has been tremendous. And I think we're going to want to do this again because there's so much more to discuss. There's so many more questions to address. We didn't even touch on maskne, which we got a whole thing together. And maybe we will try to talk less about dogs next time, or maybe more, depending on what people want. But anyway, everybody, thank you again for joining us, and thank you again to the panelists and to the Elsevier and JAAD International teams. Thank you, everyone, and everyone stay safe, and thank you for everything you're doing, both for global health and for your patients individually, because it all makes such a huge difference. So thank you so much.
Thanks.
Thank you.
Thanks, Jonathan.
Goodbye.